Okay, right, fine. So, good evening. Today will be a relatively short class because I have an emergency or a semi-emergency to attend to. So, welcome to the 16th session. So, today we are going to have a look at one of the very important topics which you need to know very well. Okay, so we are going to talk about hypertension in pregnancy, of which we have already covered chronic hypertension, right? Remember, we covered the chronic hypertension in detail and I completed everything. So I spoke to you about the causes, everything. So if some of y'all have missed, please go back and have a look at that. Right. So today we are going to talk about pregnancy induced hypertension or hypertension in pregnancy or gestational hypertension, which is one of the terms adopted by the International Society for the Study of Hypertension in Pregnancy. Okay, so there's a society like this, which is an international society which studies hypertension in pregnancy. So what they have done is they have adopted a classification which was made by two eminent authors. So it's called the International Society for the Study of Hypertension in Pregnancy, ISSSP, which has adopted this, and it has broken down or classified hypertension into four main areas. Okay, one of the areas is called gestational hypertension. That is regardless of whether there's proteinuria or not. And in that gestational hypertension, that means this is hypertension developing after 20 weeks. It's called gestational hypertension. Okay? And therefore, in a woman who has not previously had proteinuria or hypertension, right? And she develops this after 20 weeks, and that is called gestational hypertension. So this is put into three things. One is, it just says hypertension only. So if it is gestational hypertension, which means what? These are the women who have develop hypertension only, but do not develop proteinuria, right? Then there is the second category would be gestational proteinuria. This is a category of women who develop proteinuria in pregnancy, but they do not develop hypertension. Okay. The third category are the women who develop gestational hypertension and proteinuria together, which is called preeclampsia, right? Or the group where we categorize them as preeclampsia. So that is the first group. Okay. The second group, large group, is which we spoke about already, which is chronic hypertension. Okay, so these are the women who we detect or already had hypertension, probably prior to pregnancy, probably due to reasons that are chronic, right? Which we discussed the reasons. Okay, so that is the second large group. The third group is called unclassified, right? Proteinuria or hypertension, where the reason is not exactly clear. So that is the third group, while the fourth group is eclampsia, which has gone into a separate group. So those are the four basic things that we need to talk about when you're talking about the hypertensive disorders in pregnancy. Is that clear? If you look at hypertension, now we need to have a definition as to what hypertension in pregnancy means. And that is, if the diastolic, it's classified, if the diastolic is more than 110 on one occasion, or if the diastolic is more than 90, 4 hours apart on two different occasions. That is called hypertension by the International Society for the Study of Hypertension. right? Then, if you are looking at proteinuria would mean 300 milligrams in 24 hours, or 2 episodes or 2 times where the dipstick is +2, 2 positive, +2 positive dipstick reactions, or if you measure it properly, it's 300 milligrams in 24 hours of proteinuria. You measure it, and then that is called proteinuria, right? So those are the 2 definitions that you need to keep in mind. Right? It's mostly based on diastolic blood pressure. Remember, if it's 110 on one occasion, then definitely it's gestational hypertension, right? If it is more than 90 on 4 hours apart, that is also considered gestational hypertension. Okay, and proteinuria is always, remember, 300 milligrams in 24 hours, right? In a 24-hour collection. So those are the 2 definitions that you need to keep in mind. Is that clear, children? Right. So now let's look at the whole picture now, right? And I will initially concentrate on a few things, right, that we have to know about. And therefore, first of all, I will look at the history of these women who might come to you, because sometimes this population of women who develop gestational hypertension, right, with or without proteinuria, there are, in the history, if you look at the history, there may be some indications that there is a possibility that they might develop this gestational hypertension, right? Number one, in the history, if they have had previously, in previous birth, if they have had a history of hypertension or gestational hypertension, or eclampsia or preeclampsia, then there is a possibility that they might develop this again in this way. So clinically, in our minds, we think, okay, this woman, there is a possibility of them developing gestational hypertension or even preeclampsia and eclampsia. In which case, for these women, we will try to prevent it. So remember this, there are several terminology which you need to understand. The first of all, there are women, they come to you, but they don't have increased blood pressure, but we can screen them and find out which are the patients who are at a higher risk of developing gestational hypertension later on. So screening can be done or in 3 ways. It has been tried to do in 3 ways, right? Main. Number one, by history, right? That you need to understand what are the types or the risk factors in history that you can identify. The second main group is scanning. So it has been found that in some factors, there is some Dopplers have been tried out, which I will discuss later, where initially, especially in at 20 weeks, 22, 24 weeks, there are certain Dopplers or investigations which can do, which might predict the fact that the woman might develop preeclampsia at a later date. Okay. The third thing is some biochemical markers have been tried out, right? There are lots of them, right? But few stand out, right? And which I will discuss it. But these are not conventional use, and just the predictive values are not very good. So therefore, mainly we at the moment, to predict preeclampsia in the future, we use the history, right? And we use Doppler of the uterine artery, which we'll speak about later. But remember, there is always a third group, which are biochemical markers, which you do certain and try to predict gestational hypertension in the future. Now, what is the use of this? To try and diagnose it before it happens. The use of it is these women, we can subject to more intensive monitoring than usual. Okay, if we measure blood pressure in a woman when it comes to us for the antenatal clinic, right, which might be once in 4 weeks, once in 6 weeks, once in 3 weeks, right, the blood pressure might be just monitored at that time only when she comes to us. However, if we can predict in the future, okay, this woman might develop, so then you can ask her to get a blood pressure measured more frequently, maybe once a week, right, once in 3 days, right, or in such a manner that is not difficult for her, and then you can catch these early, and then you can institute more surveillance methods for the baby and the mother. So that is why these screening methods are important for patients who might develop gestational hypertension. Is that clear, children? So let's look at the history, right? What are the things that you might want to ask in the history in a woman? Number one, if she has had a previous history of preeclampsia or increased blood pressure or proteinuria, right? Then of course she's at a higher risk of developing the same in this pregnancy. These are the women. We will institute a plan of management where we will monitor them more frequently. Second thing is we will also start them on aspirin, right? Where aspirin might prevent the development of preeclampsia by about 15 to 20%, right? So we give 150 milligrams initially, starting from about 12 weeks, right? And then we continue throughout the pregnancy. So that is one thing which you can do. The second group that might develop preeclampsia or problems are the women with chronic renal disease, because chronic renal disease, which they may not be having hypertension at the moment, we spoke about hypertension, right? They might get pre-imposed preeclampsia on the already existing renal disease. So they are at a higher risk to develop that. Okay. The third category of women are the women who have diabetes or any type of impaired glucose tolerance. If there's a history or if they are diabetic, then the chances of them developing preeclampsia or pregnancy gestational hypertension is higher. So in these women, there should be more surveillance for these women, right? Next are the ones who are overweight. If they are overweight, the chances of developing gestational hypertension is high. So you remember, women who are overweight, there's nothing we can do about it in pregnancy. We can't ask them to lose weight or go on a strict diet. And therefore, however, you have to keep in mind that they might develop hypertension later. What are the other risk factors? If there is a woman who is a teenager, right? Or a woman who has undergone intrauterine insemination by a donor, right? It is thought that they might develop, the chance of them developing pregnancy or gestational hypertension or preeclampsia is higher. Why? It is thought that if a woman undergoes intrauterine insemination by a donor to get pregnant, that is number one. Or if it's a teenage pregnancy, the chances of them getting exposed to paternal antigens, because it is thought that the father's antigens or the father's component in the baby can increase the chance of having gestational hypertension. So if the woman has used a lot of barrier methods of contraception, which reduces the exposure of sperm to the antigens and the sperm to the maternal side, or if it is a donor insemination or a teenage pregnancy, right? The possibility that the antigen exposure is lower is there, and therefore the chances of developing preeclampsia seems to be higher in these pregnancies. If the baby or the pregnancy is from a partner who has in previous pregnancies, say with the previous woman, has fathered the pregnancy where the woman has had hypertension or preeclampsia. If he fathers this one, the next one, the chance of preeclampsia is high, right? Also, if there's a change in partner, a woman may have had 2-3 children, right? No preeclampsia, but now the next child is with a new partner, then there is a possibility that she might develop gestational hypertension. Why? Because the paternal antigens are new. So the exposure to newer antigens, right? It is thought that the risk can go slightly higher, right? So these are the things in the history that you might want to consider, right? Thinking that this woman can develop gestational hypertension. In which case, of course, we may start, what we can do about is 2 things, right? What are these? Start on aspirin from 12 weeks. The second thing is increase surveillance for these women. Okay, so that is basically what we want to ask in the history. That is screening. The second thing which you can try to do to find out whether they can develop hypertension is to do ultrasound scans at 20 weeks. Although the specificity and the sensitivity is not very high, it is thought that if we do a Doppler of the uterine artery, what does that mean? I will explain to you later. What a Doppler means is, if the uterine artery brings blood to the uterus, and if there's a problem in that, right, when you do a Doppler of the uterine artery, a notch can appear in the uterine artery waveform, right? If the notch appears at 20 weeks, it is thought that there's a 20% chance, 1 in 5 chance that the woman might develop preeclampsia at a later, 1 in 5. Okay, so therefore, in previously normotensive women, who have not had anything, and suddenly a notch appears in the uterine artery Dopplers in the waveform, it is thought that 1 in 5 will go on to develop preeclampsia. So that is one way of doing it, but routinely we do not really do it, but there's a possibility. If it is done at 24 weeks, the chances or the predictive values become higher than at 20 weeks, right? So those are the information that we have at the moment for the prediction. The next these are other investigations. The next thing which can predict, or we think can predict, are biochemical markers, which none of them have been found. There are lots and lots of biochemical markers which has been done, because it's thought, okay, in a woman who is going to develop preeclampsia, do some serum markers change? And it has been found that if you do serum markers in the second trimester, like HCG, PAPP, pregnancy associated plasma proteins, right? There are different kinds of hormones that can be done, and it has been found, depending on their variation, you can predict them the development of preeclampsia. So there has been some associations found. In some markers, they will go down, and you think, okay, that has, or it has been found that lower, when some markers fall lower, chance of preeclampsia goes up, or some markers become higher, then the preeclampsia goes. But various biomarkers have been found to try and predict preeclampsia, but none have been found to be clinically useful for the woman. Maybe in the future, at about 10-15 weeks time, or at 10 weeks, you can do biochemical markers or something, and then say, okay, this woman is going to develop preeclampsia, and do things to prevent that, right? Which may be in the future, but not for the woman. For the moment, what we have is the history, right? Lots of biochemical markers which are not very clinically effective, and a Doppler which might predict maybe 1 in 5, right? If it is positive, which is so those are the things that have been found. There are lots of other things, lot of trials that have been done, which are of course at MBBS level, is not necessary for you to understand. So overall, remember three things that you need to know about the prediction of preeclampsia: history, biochemical markers, you just name them, but you don't need to know them, right? Yeah, right. If you, of course, you want to go for the gold medal and all those, you can talk about pregnancy-associated plaster proteins, estradiol. You can talk about HCG, right? And Tilini is there, of course. Tilini will all say all this. I can see her, so she can also register, so she can talk about all this. So therefore, you have to talk about the biochemical markers, which you can talk. The third thing you need to talk about are the children, the Dopplers, right? So the uterine artery Doppler at 20 and at 24 weeks better, which might predict preeclampsia, which can be used. Okay. Whatever we do to predict, remember there are only mainly 2 or 3 things which you can do. Number 1 is start on aspirin. Number 2 is to increase surveillance to catch things early. I forgot something else. A previous history of small for gestational age is also a risk factor which can. Previous history of antiphospholipid antibody syndrome is also a marker which might cause a hypertension in this pregnancy. So those are the things that are in the screen. Is that clear, children? So what we have discussed about is few things. Number 1 is we have discussed about the classification, which I have spoken to you about 3 things. Main thing, I'm just summarizing everything. Main thing is gestational hypertension, which has proteinuria and non-proteinuria all clumped together, right? And that is broken into 3. Gestational hypertension, that is hypertension only, no proteinuria. Gestational proteinuria, that is no hypertension, only proteinuria. And then gestational proteinuric hypertension, which is hypertension with proteinuria, which is sort of preeclampsia, right? The second group is chronic hypertension, which might cause hypertension in pregnancy, which may be due to renal causes, different causes, which is talk about in the chronic one. The third thing is unclassified. You can't put it into anything. So it can be not classified, right? Which we talk about proteinuria, not any cause we have not found, just gestational proteinuria, which no cause has involved, unclassified, right? And the fourth thing is, of course, I told you, eclampsia or fits, right? So those are the 4 things that are. And next we talked about the prediction in the history as to what forms, mainly 3 biochemical markers, history and Dopplers, which can predict the development of preeclampsia, right? Next, let us look at the mechanisms as to what we need to understand about the development of preeclampsia or hypertension. It is thought that the placenta, right, it's a disease of the placenta. So if there's a problem in the placenta, the woman can go on to develop gestational hypertension, right? And why is that? Let's look at the development on the placenta, which you all know. So now when the baby forms, right, the baby must eat and drink, okay? And the only way it eats and drinks is through the umbilical cord. Now the umbilical cord is connected to the placenta, and the placenta is connected to the uterus. And the uterus, so the baby's placenta must get the blood supply from the uterus. Remember, the baby's blood supply and the mother's blood supply does not mix. So the only way what happens is in the placenta blood comes from the baby, they fall into lots of lakes inside, right? And the mother's blood is going on the other side, right? Bathed in these lakes, right? And the exchange takes place where baby gives all its kasalatika to the mother and then gets all the good things from the mother, and then the blood goes its separate way back to the mother. Mother clears everything and the baby gets all the good things, right? So the baby is like a parasite actually. It's called the parasitic theory as well, right? So now to do this, there must be a constant good blood supply to the placenta. And how does the placenta achieve that? Initially, its trophoblast need to invade into the spiral arteries of the myometrium, right? And to do this, the placental trophoblast involves all the growth factors and the vascular modulation factors that changes the vascularity or the anatomy of the spiral tubes. What it basically does is it changes the spiral arteries of the myometrium into just tubes without the ability to constrict. And why does that happen? Because if the mother with her hormones, and if she has the ability to constrict the placental muscle. Now, if the maternal body says, okay, I'm not getting enough blood, my brain is not getting enough blood, my liver is not getting enough blood, my spleen is not getting enough, that fellow is outside like a parasite. Let me just constrict all the placenta, all the placenta, and then get the blood for myself. Why should I supply that fellow? Okay. So if the mother's body decides that, it will put out pressure hormones, it will go to the placenta and it will constrict the blood supply. And the baby is not going to get anything. Now, a baby doesn't want that. So what it does is, it takes off the ability of the mother to constrict its own vessels of the placenta or the uterus. And how does it do that? It basically converts the muscle wall into just non-muscular tubes. Because the muscle walls have to constrict to reduce the blood supply. So this is done by what is called a trophoblastic invasion. So the baby's trophoblast, the tropho is food, blast is it divides, right? And then it divides, goes along the maternal spiral arteries and changes the muscular code. So the blood keeps coming. Whatever the mother happens to the mother, the blood still keeps coming, right? At the end, it about 500, 600 milliliters per minute comes into the placenta for the circulation, right? Now, if this does not happen properly due to a problem in the trophoblast invasion, then of course, the mother retains the ability to constrict these blood vessels. And the blood circulation in placenta is not coming very well. And that causes the placenta to be ischemic. There is ischemia in the placenta or the reduction in the placental function. And this, for some reason, due to the placental ischemia, they puts out factors or one factor, we do not know, right? And it is sometimes called the factor X, but we think it is endothelial activation factors, one or many, right? And these factors, what these factors are trying to do is to try and get more blood and more blood to itself. So these factors are trying to modulate the placental blood vessels or the mother's blood vessels into getting more blood for the vessel. Now, however, these factors, it is thought, goes into the mother's body because the baby is trying to get more blood. So it produces, the placenta produces more factors trying to get more blood. These factors escape into the mother's body and it causes endothelial activation throughout the mother's body from head to the toe. Okay. Now, because these are endothelial activation, right, or changes in the endothelium, because the endothelium is the inner lining of all the blood supply to all the organs in the mother's body, right? And therefore, what it does is it changes or damages this endothelium from the top to the bottom of the mother's body. But because women are genetically different, each person is genetically different, the damage occurs differently in different women. In some women, the endothelial damage or the activation or damage by activation, right, can be more prominent in the brain, right? And therefore, the brain cells can get more damage. And how do these women come out sometimes? With fits, because the brain gets damaged, right? So the membrane potentials there gets damaged, the stability is not there, neuron starts firing, and then she has a fit. In some women, the liver cells get damaged, and there may be problems in the liver cells. So how does the liver reply to this? The damaged cells will put out liver enzymes, right? That is SGPT and SGOT or ADST. And if we measure the SGPT, SGOT in these women, it would have gone up. Okay. Next, it might go and damage the renal tubules. Now the blood comes to the kidney and it comes to what we call the Bowman's capsule, right? And the blood gets filtered onto inside the renal tubule. Okay. Now this Bowman capsule lets in only certain amount of molecular weights into that. However, these endothelial factors can go and damage this Bowman's capsule, and because of the damage to that, larger and larger proteins will escape into the renal tubules, and therefore the woman will start excreting protein through her urine. So that is what causes proteinuria. So it is damage to the renal tubules, or specifically the Bowman's capsule. So that is because of the endothelial activation there. So then that is how the woman gets trained. Pressure is maintained by the arterioles, right? Which maintains the peripheral resistance. That you all know. Well, I hope you all know. Okay. So therefore, if there is a damage, global damage to the arterioles everywhere, the peripheral resistance will go up, and therefore along with it the blood pressure, right? And therefore most women, not all, will have, due to this damage, the pressures will go up. So that is what creates hypertension, right? The next, because of the damage to all these vessels everywhere, endothelial activation, right? Dementia everywhere, small clots will start to form. So there's a massive activation, or massive activation, very, very, very tiny activation everywhere of the coagulation system, right? And therefore that activation, plus the fact this might also damage the bone marrow as well, this activation will cause consumption of the platelets, right? It's a sort of a, not a huge consumptive coagulopathy, but it does damage to, or there is, because there's microcoagulative problems, microthrombosis everywhere, it causes damage to, it causes the platelets to be used up, and that can cause thrombocytopenia. Okay. At the same time, there can be microthrombosis, right, and endothelial damage in the liver capsule, okay, due to these factors. And what does that happen? The liver capsule has microthrombosis everywhere, and sometimes because of the coagulopathy's problems, because there is damage, sometimes there's hemorrhage because the coagulative factors have gone down, because the whole body is using it up, and therefore under the capsule there can be hemorrhage, right, which is called subcapsular hemorrhage into the liver. Okay, so this, remember, the liver is not sensitive at all, but the capsule of the liver, which is called the Glissen's capsule, is extremely tender and painful, and therefore it causes hypogastric pain, severe hypogastric pain, and especially if there is subcapsular hemorrhage, the woman even can die with that, right? So this is also due to preeclampsia. At the same time, because the proteins are getting lost from the kidneys, okay, in the blood, if you check the blood, you get loss of protein, or you get hypoalbuminemia or hypoproteinemia, right? Because the proteins are getting lost from through the kidneys out. The other thing how the women lose proteins is because there's massive endothelial damage. The proteins will escape into the interstitium around the vessels. So now when the proteins go out of the vessels into the interstitium, it leaks, right? The oncotic pressure inside the vessels will go down because it is maintained by the proteins, right? when the oncotic pressure goes down, right, inside the tubes, the ability to retain fluid goes down because the fluid is retained in the vessels by the oncotic pressure, which you all know, or I hope you know, right? And therefore, when everything goes out of that, it carries the water along with it. And inside the vessel, there is dehydration. So what do we get when you do a blood count? We get the hematocrit has increased, or which means there is hemo concentration in these patients. Okay. At the same time, when the proteins go out and the fluids go out of these vessels, in the lungs, that is not a good thing to happen because the lung interstitia becomes filled with fluid and it will have pressure on the alveoli. And what do we get? We get pulmonary edema. We get pulmonary edema, right? And that also is one of the problems that we have when we manage patients with preeclampsia. And on top of that, on leaky vessels, with a bit of pulmonary edema, if we overload them with fluid, they will drown from the fluids that we give them. And that is what we call iatrogenic, caused by the doctors, pulmonary edema, which can cause death. Okay. So I just wanted you to understand the way it happens, starting from the placenta, because the placental factors cause massive endothelial activation all over the body, right? Due to the fact initially that the problastic inflation has not taken place and the placenta has become ischemic, and it produces these endothelial activation factors, right? Or one or many, we do not know. There are hundreds and hundreds of factors that have been told, okay, this is this, or this combination, this, but none have been identified. The mechanism have not been identified properly for the moment. But what is known is there is global endothelial activation and damage, and therefore all organs get involved, some more so than the other, and therefore women might present with different pictures because different women's organs will get damaged differently and they will come out differently. So therefore, some women may not have hypertension, but just proteinuria. Some men have platelets will come down, liver enzymes will go up, and that is called the special syndrome, where we call it the HELP, right? Where there's hemolysis, right? Low platelets and liver functions will go up. And sometimes, but most of the time, women, what is damaged constantly are the kidneys and all the endothelials in the periphery, which causes increase in peripheral resistance, which causes hypertension, right? So hypertension and proteinuria seems to be a constant feature, but that is not absolutely essential. So therefore, it has the one way of looking at gestational hypertension is hypertension only without proteinuria. Okay. Sometimes in these women, only the kidneys get damaged. So they don't develop hypertension, but it's just gestational proteinuria. It's a form of preeclampsia. In some women, both the vessels and the kidney gets damaged. That is called gestational proteinuric hypertension, right? And that is also called preeclampsia. Now, if you look at the proper definition, the definition would state, if we have two organ systems damaged, right? Commonly, it is hypertension, which is the arterios mostly along with the kidney. However, if we have two system damage, we can actually call it preeclampsia. Say hypertension with increased liver function test, preeclampsia. Liver function test high, platelets are low, but however, it is found in a syndrome with features of hemolysis. So that is grouped together into what we call hemolysis. So that is also a form of preeclampsia. You all understand? So if we have high liver functions with proteinuria, that is also preeclampsia. Okay. So therefore, this is how all this is classified, and this is the mechanism in which we have to understand how this placental dysfunction will cause the overall global damage to everything and cause these symptoms to come to us. So therefore, if you want to examine or do investigations for these patients, you have to look at the mother and the baby separately or as a unit, but you need to look at both of these. And what happens is all these symptoms from head to toe, the mother's brain or brain cells and the arterial or the blood supply, they will have endothelial damage, and that can cause severe headache because it can cause edema because those vessels also can leak. So it can cause hypertension anyway when the brain fluids go up. However, it can cause severe headache if it destabilizes the membranes, or especially in the center foresight, the woman will have different kinds of visual disturbances, right? When the brain is very active, when it has been disturbed, the woman can, one moment, the woman can develop increased reflexes and clonus, right? So also different kinds of lights will flash along because there'll be changes in the retina and the center foresight, right? So there's scotomata, black spots, right? Blurring of vision, all those things, and she will start nausea and having vomiting. So there's all the brain symptoms. Then when you come down, if there is in very severe cases, if the blood vessels in the pulmonary tree has leaked, you can have pulmonary, the woman can develop what it is difficulty in breathing because of pulmonary edema. If you go down, if the liver capsule has microthrombosis or hemorrhage, right, you can have severe pain, which is called hypogastric pain, right? And if you do the investigation there, you will see then elevated liver functions there, right? If you look at the kidneys, there she'll be leaking protein. So if you do a 24-hour protein, you will find 1 gram, 2 grams, 3 grams of protein, which is, remember, the norm is 300 milligrams per day, right? How do you do that? You do a 24-hour urine correction, which means you ask the woman to pee and then outside, and then after that start at this time, okay, so 7 o'clock, she empties the bladder and starts. Then from 7 o'clock to next day, 7 o'clock, she ends by peeing into one pot. That pot, huge pot, is taken to the lab, and they will do this to make sure everything is mixed up. Then take a small sample and measure the amount of protein in it. And then since they know the volume, they will count the 24-hour urine protein. A good alternative is a urine albumin creatinine ratio, which has a good relationship or relationship with the 24-hour urine protein, so which can be interpreted in different ways. But a urine albumin creatinine is a good spot test. Also a good relationship or relationship with the 24-hour urine collection. Plus, it doesn't really matter when you collect it, right? You can collect it at any time. So therefore, it gives us a lot of freedom to look at the proteins that are there. So for kidney damage, right? Then, of course, we because for global problems, then we look at the platelet count. If it is going less than 100 per 10 to the 0.9, then we may be looking at trouble. So we know. Then if the platelets are climbing below 100 into 10 to the power 9 per deciliter, we might want to do the coagulation factors, because there is consumptive coagulopathy and there will be a derangement of coagulation factors as well, which we need to do, right? At the same time, we can look at the thrombin and the prothrombin time as well, if you are looking at coagulation, because what will happen is the because of the consumption, the coagulation will be, so easily there will be bleeding, which is maybe apparent, right? So remember, the prothrombin time looks at the external pathway of the coagulation pathway, while the thrombin time we look at the internal pathway, right? So those are the things that we need to do. So of course, the hematocrit, if we do, we look at the hemo concentration. So if you do subsequent hematocrits and if there is continuous hemo, if the hemo concentration goes up, right, then you may be looking at a problem, right? At the same time, so I think we have covered most of the investigations that we can do, all right? And when there's hemo concentration, the hemoglobin also might climb up with it at the same time, right? So these are the things that we will want to or do to investigate this problem. Right? Okay, so what I wanted today actually, because I don't have much time, I wanted today was to give you all an overview as to what happens in pregnancy or gestational hypertension, right? So next time, next lesson, we will continue with the preeclampsia, we'll continue with eclampsia and how we treat it and what we are going to do about it throughout the pregnancy, right? So that is the next lesson. I think we will finish that off because this overview is extremely important for you to understand stepwise as to what is happening. So the next time we are going to concentrate more on the practical aspects of management of women, how to manage eclampsia. I will talk to you how to manage preeclampsia. I will be speaking about all the principles of management of preeclampsia and eclampsia, right? And then that should complete our whole sessions on hypertensive disorders in pregnancy. Okay, right. So any questions that you all wanted to ask? Because I have to go now, so I will wrap it up now. Any questions? You can type in the questions if you want. So it's a short session, but anyway, that's also good. Well, I presume that everyone has understood. So this is just a teaser for the next lesson, which is going to be on management of preeclampsia and eclampsia, and I'll be doing the full management of those conditions in the next lecture. Okay. What about the UACR ranges? 300. Urine is about anything over 300. We consider them to be elevated. So that's also 30, not 300, 30, right? We consider that to be elevated. Okay. Anything else? Okay, so that's fine. So then we wrap up today, and then next week we'll talk about the other topics. Okay. Okay. Good night. I have to go.